Thanks to Lynn, Bob, and the team for inviting me. Thank you all for coming. My name is Ian Davis. I'm a cardiologist for the Shore Medical Group. I'm also the heart failure director for our cardiology group at our hospital in Easton. And I practice in Easton in the hospital and the clinic, as well as in Cambridge. My background is mostly in Baltimore. I did all of my medical training there, residency, medical school, fellowship. And before I decided to do cardiology, I was very interested in diabetes and metabolism. And so that kind of evolved into my cardiology career, where I'm very interested in the treatment and management of heart failure, but also the prevention of treatment of heart failure. So what I wanted to do today is basically survey all of cardiology in about an hour, which is going to be a whirlwind tour for all of you. What I really want to try and do is hit the high notes of management, treatment, and what we can all do to keep our hearts healthy. And I'm hopeful that we'll be able to touch on some exciting technologies, some advancements in cardiology, some cutting-edge things that have come up recently, and put it all together. So I don't have, in medical talks, you always have to do this at the start. I have no financial disclosures. I don't make money off anything. I don't have any stock to mention. So everything I'm talking about and promoting is because I think it's interesting, or it's actually worthwhile to talk about. And the other thing to mention is nothing I'm about to say should replace the relationship between you and your provider. This is sort of for general educational purposes. And with that in mind, we'll go ahead. So my objectives today are, I want us to all learn some of the common causes of the different types of heart disease. I want us to recognize the recommended treatments, and lastly, to develop methods so that we can all keep our hearts healthy. But the really overarching theme is that heart disease is extremely common. I'm sure all of you know someone who's been diagnosed with the condition. And I really want you to leave here feeling empowered to be participants in your own care or your loved one's care. Ask the questions, understand the treatment, understand the testing. So we're going to start with a little bit of anatomy to start. This is not an anatomy lecture at all, but we need to know some common terminology so we can all discuss these topics. So the heart has 4 chambers primarily. There are 2 chambers at the top of the heart, which are called atriums, or atria. And much like architecture, they're places for blood to gather. So blood comes from the veins, from the body, gathers in the right atrium. It is then moved into the right ventricle. The ventricle pumps that blood off to the lungs to be oxygenated. The oxygenated blood comes back to the left atrium, which is the next collecting chamber, and then the ventricle pumps it out to the body and the tissues and the brain. There are several arteries to mention related to the heart. There's a lot of them, but the really important ones to mention are the left main artery, which then gives rise to 2 arteries called the left anterior descending and the circumflex artery that wraps around the back. And then on the right side of the heart, there's a right coronary artery. And these arteries are what supplies the heart muscle with the blood that it needs to function. There's also an electrical system, believe it or not, involved in the heart. What this graphic is showing is that basically the electrical signal for the heart starts up here at the top in what's called the SA node. That electrical impulse comes to the middle of the heart at the AV node, and then the AV node functions as a speed limiter, basically, and it allows electricity to go down through an elegant conduction system and lets the heart contract. And then last thing to mention is there are 4 valves associated with the heart. On the right side, the 2 main valves are called the tricuspid valve and the pulmonic valve. So the tricuspid valve divides the right atrium from the right ventricle, and the pulmonic valve allows blood to come out of the right ventricle and go to the lungs. And then on the left side, there's 2 main valves. One is the mitral valve that permits blood to come from the left atrium to the left ventricle. And then there's the aortic valve, which allows blood to leave the heart and go out to the body. Okay. So that's it. That's all of heart anatomy. It took me 7 years to master that, and you guys got it in 1 minute, okay? So let's start with talking about perhaps what is the most common form of heart disease, certainly in the United States and worldwide. That's coronary artery disease. Now, I'm going to break this down in the way I think about it, and the way I explain coronary artery disease to my patients. So there's kind of two kinds of coronary artery disease. There is what I like to think of as the progressive or chronic form of coronary artery disease. Basically, over time, our bodies and our blood have cholesterol inside them. And over time, that cholesterol gets deposited in the walls of the artery vessels. This is a process that affects all of us. I'll be honest with you. During the Vietnam War, unfortunately, young, healthy GIs, 18, 19 years old, passed away. And there were autopsy studies. And we saw on those studies that even at the age of 18 and 19, we start to see the start of this process. There's cholesterol deposited even at an early age. Over time, depending on the person and some of the factors which we'll talk about, that hardening and that plaque may progress and develop and get bigger and bigger and bigger until one day people may start to develop symptoms. And we call that angina. Then there's another kind of coronary artery disease that I think of as being sort of sudden or acute. So as this cholesterol gets deposited in the wall of the vessel, suddenly that cholesterol may rupture out and go into the vessel itself and suddenly close off the vessel, very dramatically. This is perhaps what we think of when we think of a heart attack, sudden, chest pain, having to go to the hospital emergently. This is the sort of dramatic form of coronary artery disease, and it can be potentially life-threatening. I'm sorry, I'm getting a phone call. About work. Work's not work right now. There's many ways that we may end up diagnosing the kind of stable form of coronary artery disease. Sometimes people have heavily family histories. Dad had a heart attack at age 50. Grandfather had 4 bypass surgeries. And that prompts, the medical system or your doctor to sort of go looking for it. Sometimes we see it incidentally, meaning you get a CAT scan for some other reason. You get a CAT scan of your chest because, something hurts, and we see, oh, look, the vessels look like they're not quite healthy. Sometimes we intentionally order tests, which I'll talk about in a moment, to try and figure out who is at risk. And then as we go sort of further down the progression, some people may present with symptoms. They may present with chest pain or shortness of breath. Or if it's found in a very late stage, some people may actually be in heart failure, which we'll talk about a little bit later. So there's a spectrum to when we kind of figure out who has heart disease and what we do about it. So I'm going to talk about some of the diagnosis tools that we use to diagnose heart disease, or coronary artery disease, I should say. One of the most common is an EKG. I'm sure everyone in this room has had an EKG or seen an EKG. The thing about EKGs that I want to point out to people is that they are sensitive but not specific. So what does that mean? What that means is EKGs are designed to catch a lot of things, right? It's very easy to perform an EKG. It's no risk to the patient. Anyone can do it anywhere. But the problem is it can catch a lot of things that may or may not be real, right? So maybe you've been told, or you have a family member who's been told, your EKG is abnormal. But does that necessarily mean there's a problem or not? Not always. So we usually have to do more testing. EKG is not sufficient alone to diagnose things. Something that I'm very into in terms of the diagnosis of heart disease at an early stage, so before people have symptoms, is this thing called coronary calcium scoring. What this basically is it's just a regular good old-fashioned CAT scan that we do, and we basically aim it at the heart. And what we're looking for is basically as the heart vessels get hardened over time, I told you about that progression, that slow progression of the hardening, those vessels actually light up on our CAT scan. They calcify, they harden. And so here you can see this is a heart, and these are the vessels, these little squiggly lines that you may or may not be able to see. And then you see here the same squiggly line, but with a little white dot. And then you see here the squiggly white lines with lots of white dots. And then you see at quite an advanced stage, lots of whitening of the vessels. Now, the issue with this is that it doesn't tell us if there's any blockages, but what it does tell me is it gives me kind of a sense of an individual patient's risk. So I know that a young patient with a high coronary calcium score is sort of a higher risk person, someone I need to spend a lot of time working on their risk factors. Then at a more advanced stage, if we suspect there may be blockages of the vessels, then we start to get to what's called stress testing. There's many different types of stress tests, but they generally fall into two categories. One is called exercise stress testing, which basically is we take the patient in question, we hook them up with a bunch of EKG stickers and blood pressure cuffs, and we make them exercise. And we make them exercise according to this thing called the Bruce protocol, which is basically the patient walks, and the speed and incline of the treadmill is increased gradually over time. And as their heart rate comes up and they start to exercise more and more, we look for EKG changes, which may be suggestive that there are blockages of the heart arteries. And then there's also what's called pharmacological or nuclear stress testing. The concept here is that basically the patient is given a mildly radioactive tracer and then given a medicine that causes the blood vessel to dilate. And we take pictures before the dilation and after the dilation, and then we compare those two pictures. We look at them. And if there are areas of the heart that are different, say here and here, you can tell there's quite a distinct difference between these two. That suggests to us that there's a blockage in the heart artery. There's also ways to kind of combine these two, I should say. Sometimes we do exercise plus the nuclear part. Sometimes we only do one or the other. That's kind of a specific thing. But anyway. And then what ends up being the gold standard, meaning the definitive test for coronary artery disease, is this thing called coronary angiography. It's also referred to as a left heart catheterization. You'll hear that term thrown around. It's basically the same thing. But it's basically a process where we, in the hospital, take the patient, give them medicines, make them very comfortable and relaxed, and we use a small needle that gets placed in one of the arteries in the body, and we can introduce small plastic tubes that are guided up the arteries to the heart, and then we inject contrast dye into the arteries to allow us to visualize in real time what's going on with the blood vessels. There's no real better test than this for us to be able to see what's going on with the vessels. It does carry a little bit of risk. Obviously, it's an invasive procedure. We're using contrast dye, we're using needles, but that risk is quoted at around 1 in 1,000 for something, bad happening. So it's, as you can tell, it's not so risky. It's not like a massive surgery, but there is some risk to it. And this is basically what we end up seeing. So you remember I showed you the vessels at the start of the talk. This is the catheter that I mentioned. It's introduced into the aorta, and it's injecting contrast dye here. And you can see this is the left main that I mentioned, that LAD that's coming around. You can see the left circumflex here. Because this is a 2D image, you have to imagine this is actually going into the plane of the screen, kind of wrapping around the back. And this was that right coronary artery I mentioned to you. These are very healthy looking vessels. There's no issues here. But you could imagine if there was a blockage here, maybe we wouldn't see the rest of the vessel. That's kind of the concept. And then something that's really important to mention is, I've been diagnosed with coronary artery disease, or I'm at risk for coronary artery disease. How do we prevent it? How do we prevent progression? There's several different parts that go into the progression of coronary artery disease. One big one is cholesterol. I mentioned at the start of the talk that cholesterol is really the fuel that basically feeds the progression of that slow hardening of the plaque of the heart vessels. There's many different medicines that are out there to treat this, to lower people's cholesterols. One of the most common that you'll hear about, obviously, are statins. There's many different types of them. Many people are on them. They're very common. There are also other newer medications that are out. There are medicines called PCSK9 inhibitors. They're basically injectable medicines that we use that basically block the liver's ability to kind of turn good cholesterol into bad cholesterol. They're very effective. There are other medicines that work on the gut that prevent people from absorbing it. There's all types of different cholesterol medicines out there. The next one is blood pressure. So controlling blood pressure is very important for keeping the vessels healthy and basically slowing progression. What becomes more interesting is what's a normal blood pressure? What should our goal be for people? This is something that's actually a little bit in flux at the moment. In the older days, and when I say old days, I mean like 15 years ago, we used to try and make basically everybody's blood pressure normal. What we've started to learn is that with our older patients, we may not be doing them a service and helping them by making their blood pressure perfect. And so newer guidelines have suggested that maybe we should allow people to be a little more hypertensive than we used to be. The reason why is because it's not as clear that we're helping them, and we may be causing side effects with the blood pressure medicines. The way I think about it is I basically try and personalize it to each person, right? So what are the medical conditions the person has? What's their own blood pressure? What kind of side effects do they get with the medicines? And we try and create kind of a personalized goal. If someone has perfect blood pressure and they're doing fine and they're not having any side effects, that's great. No problem. But if people are having a lot of side effects, maybe we don't need to be as strict as we used to be. I just want to put that out there. Another thing is if someone has diabetes, we want diabetes to be controlled. A high blood sugar can predispose people to more progression of coronary artery disease. I put in here A1C controlled, so meaning normal blood sugar without lows. I worked in a research lab for a few decades where we were studying how low blood sugar, also called hypoglycemia, may also contribute to heart disease as much as high blood sugar. But this is kind of a new thing. It's not out there as much. This is something that's definitely being studied at the moment. There are other substances that we put into our bodies that can predispose us to heart disease. Smoking, non-prescribed drugs like cocaine, and other stimulants can predispose people to heart disease. So if patients do those things, we try to get them to cut back or quit. And then second to last one is also exercise. This is really important. If you take only one thing away from this talk, this is probably it. The American Heart Association recommends that we exercise about 150 minutes a week of moderate exercise. I know I don't achieve that. I don't know about other people in the room, but that's the recommendation that we should be doing to try and keep the vessels healthy. Now, it doesn't have to be a Lance Armstrong impression. You don't have to be out there, cycling really hard for long periods of time. Moderate exercise is unique to each person. So getting the heart rate up a little bit, getting a little out of breath, maybe a little sweaty, in whatever exercise that you like to do, that counts. I know people sometimes have joint issues or arthritis issues. So what exercise means for each person is going to be different, but we should be trying to get active about 150 minutes a week. And then lastly, let's talk about food. This is a big one that comes up frequently. So let's talk a bit more about that. I frequently get asked, well, what's the best diet for my heart? What is the diet that will prevent heart disease, or if I have heart disease, stop it from progressing? This is really hard to say. In research, the way we do research is we basically control something. We give someone a medicine, someone a non-medicine, and a placebo, and then we see what happens. It's impossible to do that with food. You can't make people eat something or not eat something in reality. And also, food takes a really long time to have an effect on the heart. So it's really hard to design good science on this. And that's why if you pick up a magazine every 2 or 3 years, you'll see, well, wine is good for your heart. No, wine's not good for your heart. This is good for your heart. That's not. It's because there's these cycles in the research, and nothing is really definitive. That said, what does seem to have the most evidence for it is a diet that's rich in plant-based products, greens, fruits, legumes like beans, whole grains, and leaner types of protein like fish and chicken. And in terms of oils, the more avocado and olive oils tend to be better for the heart. Now, for those of you, for the discerning members of the audience, you may notice that I basically just described a Mediterranean diet. And that's true. That's probably, if you put my feet to the fire and say, what's the best diet for my heart, that's probably what I would say. People will come to me and say, well, I lost 50 pounds using a ketogenic diet. Is that good or not? It's really hard for me to say. One of the things that I looked at when I was sort of in the endocrinology world is we kind of looked at different diets and kind of compared them. And what ends up happening is the diet that is best is usually the one you can stick with, right? So if you do a ketogenic diet for 2 months and then stop it because it's hard to do, and then you just go back to what you were doing, that's no good. So really the diet that works for you and your family tends to be the best one. But I think trying to get more of these things, greens, fruits, beans, grains, fish, and these other plant-based oils, that's the way to go for heart health. And it's all about balance. I'll never tell my patient they can't eat something, Life's about balance. If you want a cheeseburger, have a cheeseburger. But it should be a treat. It should be instead of a 4, 5, 6 times a day kind of, or a week kind of thing. Excuse me. Jackie knows I almost just described my diet. So what if we get to the point where we have heart disease and we now have symptoms? Well, what should we do about this? In general, there's kind of 2 philosophies. One is to try and use medicines, and the other one is to try and open the vessel. This is kind of a sticking point that I think a lot of patients probably struggle with. In this kind of slow, progressive, chronic heart disease that finally gets to the point where it starts to cause symptoms, believe it or not, medications actually outperform going in and opening the vessels back up. Now, this is different. Now, to be very clear, this is different from the very sudden heart disease that I talked about. But the slow, progressive heart disease, medications outperform. So, I'll frequently meet patients in the clinic. I'll say, well, I want to start doing all these heart medicines. And they'll say, well, why aren't we, going in and doing a bunch of catheterizations and all this stuff? It's because the catheterizations can help with symptoms. There's no doubt about that. I'm not arguing that. But in terms of getting patients to live longer with chronic heart disease, the medications are the way to go. So what are the medications for coronary artery disease? This slide gets a little bit busy because I'm trying to make a point, so don't try to memorize everything. But there's kind of several ones that are important. One is basically what I call aspirin or super aspirin. So these are medicines that prevent platelets from sticking. They can prevent the big heart attack that I mentioned, and it can also slow the progression of heart disease. That super aspirin thing, it's kind of a vague term, they're medicines like aspirin but are stronger, like Plavix, ticagrelor, prasugrel, if you're familiar with some of these medicines. I already mentioned the statins. The statins not only lower cholesterol, but they have anti-inflammatory properties. They basically stabilize some of the plaques and prevent the big sudden heart attacks that I mentioned. Beta blockers, commonly used for blood pressure, but they can also be very important in heart disease to try and relax the heart, and they improve mortality. People live longer on these medicines, probably because the heart is more relaxed and dangerous heart rhythms are avoided. And then certain blood pressure medicines like ACE and ARB can also help patients with heart disease live longer, thought to kind of help the heart remodel in a good way. And then there's a whole bunch of different medicines out there that we use to try and control symptoms. I won't really mention them. There's a whole variety of them. They're out there. So we talked about the medicines. Well, then how do we open the vessel back up? During that coronary angiography that I mentioned earlier, if we do end up seeing a blockage during that coronary angiography procedure, what can be done is during the procedure itself, a small wire can be advanced from the catheter into the vessel that is diseased. The wire can be taken across the blockage, and on the wire is loaded a stent and a balloon. And then once the stent is across the area that is blocked, the balloon is inflated and then deflated, and what's left behind is a stent, which is basically, you could think of as like a space-age metal scaffold that basically keeps the vessel open once the balloon goes back down. And then the whole thing is removed, and the vessel is left open And what's really amazing about these stents is over time, patients' cells will grow into the stent themselves, and they'll heal their own cells into the stent, and it almost kind of becomes a part of the vessel. I actually brought a balloon. In the interest of time, I think I'll do that toward the end. I'm going to try and crank through because I want to make sure we get through everything.
Real quick question.
Yeah.
Is the stent made out of plastic?
Great question. There's different types of stents. In the first stents were what we call bare metal, meaning it's just metal. In more recent years, we have what are called drug-eluting stents, which they're still metal, but the metal itself is coated with a medicine that slowly seeps out from the metal itself, and it allows that healing process to happen more easily. And then it's become even more advanced. Recently, we're starting to use cobalt, titanium, space-age metals that basically allow the healing process to happen even faster than we ever thought possible. So this is a technology that's constantly evolving. Good question. In the olden days, we used to just use the balloons. We didn't even have stents at all. We would just balloon the vessel open and hope for the best. So the stents have been a big advancement. And then let's talk about bypass grafting. So for certain patients, we may recommend bypass. Okay? So what is a bypass? A bypass is a surgical procedure where the patient's chest is opened, the pericardium, the sac around the heart, is opened, and vessels harvested either from the leg or the chest wall are surgically taken, implanted into that aorta, and then implanted past where all the blockages are, hence the bypass, right? So if you have a blockage, say right here, you take an artery from the chest wall, connect it to the aorta, and then you put it down here past the blockage and allow the graft to fill the blood vessel. Well, why would you ever do that if you have stents? Who would want a bypass surgery? This is one of the exceptions in chronic artery disease. There does seem to be a mortality benefit for certain patients. So if surgery is a good idea, so if you don't have a lot of medical issues, it's a relatively straightforward candidate. If there are multiple blockages, and especially if the patient has diabetes, going for a bypass surgery may help that patient live longer with heart disease. So if you know anyone who's had a bypass surgery, this is kind of the thought process. The way I talk to my patients about this is a major surgery. There's no doubt about it. It's a big investment in time, risk, and recovery. But if we do this with the right patients, the payoffs down the line can be massive. They can live longer, less symptoms, all the things that we want. So in the right type of patient, this is something we sometimes recommend. And so kind of getting toward the end of coronary artery disease, let's talk about the sudden heart attack. The way we diagnose this is usually in the hospital, and the diagnosis is really based on the EKG and the troponins. A troponin is basically a blood lab that we can draw from the patient and detect damage to the heart. So if the troponin is elevated, that suggests to us that there may be heart damage. And then we combine that with some of the EKG findings, and we can figure out if the patient is having a sudden heart attack. There's kind of a spectrum to this. I don't want people to get hung up on all the letters and whatever, but there's sort of a spectrum to this. And on the most extreme side is this concept called the STEMI, which is the ST elevation myocardial infarction. This is the most dramatic, sudden, life-threatening type of heart attack. It has these large, very unsubtle EKG changes. And what that tells us is that the vessel is suddenly and completely occluded, and that person needs to go get a catheterization emergently. Jan and I can talk to you. Our hospital is monitored on how quickly we get our patients who have STEMIs to the cath lab, how quickly we treat them. This is an important thing. This is an absolute emergency. Shy of that, there's kind of a spectrum to this. There may be a minimal occlusion, a partial occlusion. The troponin might be a little elevated. The EKG may be making some changes. The cardiologist kind of figures out, but it lies on a spectrum. It's basically what I'm trying to tell you. And then one thing to mention about troponins, because I see this frequently, there are other things besides a heart attack that can elevate the troponin. This is very confusing for some patients. Just because the troponin is high doesn't necessarily mean that you have a heart attack. We kind of have to use a lot of different types of testing, and we have to sort of use our clinical sense to figure this out. But some patients will, say, "Oh, my troponin was low. Did I have a heart attack?" Maybe, maybe not. Basically, what a troponin is this is a molecular view of the heart muscle, and the troponin is just this tiny little part of one part of the molecules that slide past each other to make the heart work. And there are lots of things that can make troponin leak out to the blood besides a heart attack. Okay, that was a lot of information quickly on coronary artery disease. I want to pause for a couple of questions about coronary artery disease specifically before we move on to the next thing, if anybody has any questions.
I have a very basic question,
Yeah.
which everybody probably knows but me. And blood pressure, what are the two, what's over what?
Oh, that's a fabulous question. So blood pressure is systolic over diastolic, and it's basically the blood pressure when the heart is contracting and the blood pressure when the heart is relaxing. So we care about both numbers, and I could probably spend an hour talking to you about why they're different, but yes, that's kind of the premise.
Thanks.
You're welcome.
How long does it take if somebody ends up in the ER before one of the doctors there recognizes, oh, let's give them a troponin test and see what's going on?
That's a great question too. So for anyone who comes in with chest pain, one of the standards is we get an EKG really quickly, and that's our trigger to go to the cath lab emergently. If the EKG is done and it doesn't quite look like an emergent type of STEMI type situation, then we get time, and we may check several troponins. We may check a troponin every 4 hours or 6 hours and look at what the troponin does over time. Because if you have a heart attack now, the troponin comes out into the blood later. It takes time. So there's this concept of the ACS rule out. So some patients may come into the ER with chest pain, and the doctors will want to check 2, 3, maybe even 4 troponins before we say, I think we all feel better about this. We sometimes get into gray areas where the troponins are a little bit elevated, but we're not 100% sure whether this is a heart attack or not. So we may do more testing, like a stress test or an echocardiogram, or even the coronary angiography intervention.
That's pretty much the standard care right now, right?
It is. This country has gotten extraordinarily good at finding people who are having heart attacks because of this troponin thing. It's high sensitivity, so it catches virtually every heart attack, but it doesn't necessarily mean that the patient is having a heart attack if the troponins are high. It's a good question. Yes?
When I was in my 50s, I would go for a walk and I would get these very horrible neck aches. So I told my doctor about it. She immediately sent me for testing, and they said, you need, I think, 3 or 4 sticks. So I went in for the operation, and while I was getting the stent implanted, I had a heart attack.
Yep.
I mean, I can't imagine a better place to have a heart attack, but
Yeah.
so my question is, did the implanting loosen plaque or something that would cause the blockage? And 2, why was I getting pains in my neck rather than in my chest?
That's such a good question. Let's go back through both of these. The first one, this term angina.
Yeah.
Angina means chest pain, but the reality is not everybody gets chest pain. Right. Some people get what we call an anginal equivalent, meaning they get some other kind of symptom that is like chest pain for someone else. So some people may get neck pain, some people may get shortness of breath. 10% of people actually get scapular pain, believe it or not, back pain instead of chest pain. Believe it or not, as a fellow, I saw a patient whose anginal equivalent was hiccuping. We put them on a treadmill and got them on the treadmill, and they started hiccuping at peak exercise, and we saw the EKG changes. That's not to freak you out and say every symptom you ever have is a heart attack, but the point is a really good one. There's a diversity of ways people perceive things in their body, and it's not fully understood. Certainly patients with diabetes are more likely to have non-typical symptoms. Women are actually more likely to have non-typical symptoms. There's what's called the red dress campaign, which is to bring awareness to this. So I'm glad you pointed that out. But basically, any severe symptom that is happening at peak exercise may be worth investigating. Now, your next question about what happened during the catheterization. It's hard for me to know, to speculate. One of the things that can happen is, if there was a blockage and they go in and start to do the work, does some of that blockage go downstream and create new symptoms? There's a billion and one things that can actually happen during a catheterization. The risk that we quote for people is about 1 in 1,000 of something worrisome happening during the catheterization itself. So I'm sorry that happened to you.
You're special.
Yeah.
Well, I mean, if it was going to happen, that was the right time to happen.
That's true. That's another way. That's a really good way of thinking about it. I just hate to hear that anyone had anything like that while they're getting treated. But yeah, it's a great question. Yeah.
It's about statins. I was prescribed statins, and I noticed a severe difference in my ability to remember things, names of things, whatever. And somebody brought that to my attention, so I stopped. And I take red juice rice. And so, what's your experience with that?
Did you find that your remembering things got better?
Yeah.
Okay. Oh boy. So I'll be honest. I think I spend probably 20% of my time talking to people about side effects from statins.
About what? Oh,
Side effects from statins. I'll be very diplomatic. There are a lot of potential side effects. Not everybody gets them. I can't comment on your particular case, but I can argue with what you experienced. So that is what it is. So some patients take to it great, have no side effects. That's wonderful. Other patients have side effects. What the study suggests is just because you had an issue with one statin doesn't necessarily mean you'll have an issue.
yeah.
You tried to and same thing. You're lucky. I'm sorry, but I can't comment on your specific case, but yes, people get all kinds of side effects. We try to get people on doses that work for them, not with side effects, but you're right. Sometimes we got to do a little trial and error, sometimes we got to figure it out. That's a good question. All right, I think I'm going to move on to our next section. If there are more questions about this, we'll pause again at the end. So next, let's talk about valves. I'm going to go through this a little bit more quickly because this tends to be more of a surgical issue, and I'll mention, you'll see what I mean in a moment. There are basically two issues that can happen with valves. One of two things. It can either be too tight, which we call stenosis, or it can be too leaky, which we call regurgitation. It can't really be anything other than those two things. Although sometimes it can be both. And so how do we diagnose valve disease? The diagnosis of valve disease really centers around echocardiography. What echocardiography is it's basically using special piezoelectric crystals, which means crystals that when they're exposed to electricity produce sound waves. And we use those sound waves on devices to go into the patient's body, bounce off the structures, and then as the sound waves come back, we can interpret those sound waves as images. This image became extraordinarily grainy, I apologize, but what you're seeing here is someone with a probe in their hand using sound waves to create an image of the patient's heart. This is called transthoracic echocardiography. This is really nice because it's no risk to the patient, there's no radiation, there's no, it's non-invasive, it just takes a little bit of time. And what we can do is get a lot of information about how the heart looks, how the valve looks. We can even detect pressure and blood flow across the valves. We can get tons of information using an echocardiogram. And then if one of your doctors suspects that there may be more of a specific issue with the valve, they may recommend what's called transesophageal echocardiogram. This is a special type of echocardiogram where a probe is actually placed in the patient's mouth and it goes down the esophagus or the swallowing tube. And on the probe itself is the ability to send out these sound waves that I'm talking about. And we can make much clearer images of the valves. This is usually reserved when we're thinking about, we need to do something about a valve, we need to visualize the valve for the surgeon, that kind of thing. Valve disease severity, whether it's too tight or too leaky, can be graded as mild, moderate, and severe. As you can imagine, we are more worried about severe. And so let's talk about the specific types of valve issues. The most common one in the United States, and the one that's most associated with aging, is called aortic stenosis. So we mentioned the aortic valve is the valve at the top of the heart that lets blood go out to the aorta. As you can imagine, even from before the moment you were born, that valve was opening and closing 60 to 100 times a minute, 365, the entire time you're alive. Over time, that soft, pliable, nicely moving valve, when you were 20 years old, at some point may start to harden, get a little bit creakier, doesn't open as well, and that can prevent blood flow from coming out of the top of the heart. Patients typically experience this as an exertional chest pain. They may get dizzy when they walk, or they may even have heart failure symptoms, and we'll talk about that later. There's two ways to fix a tight aortic valve. One is called a transaortic valve replacement, or TAVR. This is a procedure where a catheter is introduced into the patient's legs. A wire is placed across that aortic valve that we're talking about, and on that wire is loaded a very large balloon with the valve itself scrunched up on the catheter. It's able to go into the patient's blood vessel, and then the balloon and valve are positioned across the stenotic, the tight valve. The balloon is inflated, and what's left behind is basically, it's similar to a stent. It's a metal scaffold, and inside of it is a new valve that functions in place of the old one. Very cool. This is something we get very excited about in cardiology, because in the old days, our only option for a tight aortic valve was surgery, basically opening the patient's chest, opening the patient's heart, stitching a new valve in. And as you can imagine, if this is a process of aging, well, not everyone is going to be a good candidate for the massive open heart procedure. So now that we have this technology, we've been able to help a lot of older patients with aortic stenosis with their issues. Younger patients, we may suggest, there are other types of aortic stenosis, so younger patients can get it because of congenital issues and whatnot. For younger patients, we may recommend the surgical one because we believe this to be more durable. I say believe because this technology is a little bit newer, so we don't really know. Then that aortic valve may get leaky. So here, this is actually a nice image of an echocardiogram here. This is that aortic valve. The aorta is coming out this way. And this blue jet that you're seeing there is actually blood going the wrong direction from the aorta back into the ventricle. Basically, when we think about regurgitation, we think about is it sudden or is it chronic? If it's sudden, you usually think about infection. Is the valve infected? And that can be an emergency. If it's chronic, we kind of think about the same thing as the stenosis. Is the valve getting sort of creakier, not working as well? Is the aorta itself getting a little bit larger? Treatment for this is generally surgery. I put here a couple images. This just shows kind of the aorta getting larger and then the leak getting worse, and some echo sort of images of that. And then I mentioned the mitral valve, which is that valve between the left atrium and the left ventricle. That valve can also leak. And again, we think about, is it acute or is it chronic? If it's acute, heart attacks can actually do this, believe it or not. A big heart attack can cause the valve to become suddenly leaky. Again, infection of the valve can do it. And again, if it's chronic, we sort of think about the heart getting larger, the valve not working as well. Patients may have shortness of breath or heart failure symptoms. And then this is just kind of a picture of that. This is sort of a normal mitral valve with blood going the right way. And then in a leaky mitral valve, when the heart squeezes, the blood goes the right way, but it also goes the way you don't want it to. Treatment for mitral regurgitation is this. There's some kind of advanced things here that are pretty neat. Generally, the treatment is surgery. We can replace or repair the valve. One of the nice things about being in the University of Maryland system is we have robotic surgery actually available, minimally invasive robotic surgery at the downtown campus. Not everyone's a great candidate for this, but if it is, it can be nice. It's a much less invasive way of getting the valve fixed. And then another newer technology is this thing called MitraClip, which is basically, this is going to be a theme that I'm going to keep saying over and over again. Catheter put in the groin, in the blood vessel. It's brought up to the heart. It actually goes across the two chambers. There's a wall between the left and right atrium. We put the catheter, we poke it through the, believe it or not, the atrial wall, and then loaded onto the catheter itself is, I think this looks like a Batman, like a grappling hook. And that hook is basically pulled back. It clips the valve and brings the valve leaflets together and reduces the amount of regurgitation. It's very, very cool.
Do you mean Easton, John?
Oh, excuse me, I'm so sorry. I mean in Baltimore, at the UMMC campus. Thank you, sorry. A lot of our cardiac surgery from the Eastern Shore, we send to Baltimore. Good question. So I'll finish up the valve talk. The way I was trained in fellowship was I was told there's no medicine that prevents aortic stenosis. There's no medicine. There's nothing. Well, it turns out this year there's a newer medicine that's showing promise in phase 2 trials for slowing the progression of aortic stenosis. It's called adasigwat. It's not ready for prime time yet by any means. It's only in phase 2 trials, but it's interesting. The paradigm about only sort of fixing these valves mechanically may be changing. All right, let's talk about any questions about valves, about anything about what I said about valve treatment. Good. Oh, yes, sir.
I heard a lot of times that they were using pig valves or something. You know, you showed the first one was a totally inert one, but what are the valves that are being replaced now?
Yeah, that's a good question. So there are different types. The TAVRs tend to be what we call bioprosthetic, meaning they are a combination of a tissue, which is usually cow, it's usually bovine, as well as non-tissue components, this sort of metal scaffolding. There's also some fabric that's woven in there, so it's kind of a combination of all things. The tissue is harvested from an animal, you're right, but it's decellularized. It's basically all the cells are killed, and what we use is kind of the leftover parts of it. It is well tolerated. I know it sounds gross to think that you have part of an animal inside you, but it tends to be how we make these things work. Just wait till I talk to you about heart transplant. It's a good question. Does any other questions about valve disease, treatment? Okay, great. So let's talk about my sort of favorite topic, which is heart failure. Heart failure is a all-encompassing term that basically describes the heart is not able to push blood forward effectively. Okay? So if you imagine a pump that you may have on your boat or on your pool or whatever, if the pump isn't moving the blood forward, that pressure builds up behind it. And that pressure may come out for patients as shortness of breath when they walk, trouble breathing when they're lying flat. That's a big one because if you imagine when you lie down flat, gravity pulls pressure into the lungs and make people feel short of breath when they lie down flat. Some people, if it gets really severe, may get fluid in their lungs and swelling in the legs. There are many different ways to diagnose and classify heart failure. Probably the easiest way is to actually think about that echocardiogram I mentioned. There's kind of 3 general flavors to heart failure. One is called heart failure with preserved ejection fraction. So what ejection fraction is the ventricle itself contracts. And when it contracts on the echocardiogram, we can see what percentage of blood moves forward. If the patient's heart is contracting normally, but they still have normal heart function, the issue may be that their heart isn't relaxing normally. So the heart needs to not only contract, but it needs to relax, kind of like a spring. And if the heart is having trouble relaxing, that pressure inside the heart can build up and cause those symptoms that I mentioned. There's also this thing called heart failure with reduced ejection fraction. So this time the heart is not contracting normally. The amount of blood being pushed out with each beat isn't what it should be. We say that the ejection fraction is low, the walls are not contracting normally, and generally speaking, we think about heart failure with reduced ejection fraction as being because of blocked heart arteries, which we already talked about, or it could be because of a billion other reasons we call non-ischemic, meaning not blocked heart arteries. And then I've been talking about the left side of the heart, the right side of the heart will become weak. I mentioned, the right side of the heart pumps blood up to the lungs. If the pressure inside the lungs becomes very high, and that's a whole talk in and of itself, this right side of the heart may get weak, and blood may pool and not move forward, and that can cause issues as well. This tends to be less common, more rare, and usually requires kind of a subspecialty type of treatment, going to see a pulmonary hypertension expert. It's its own thing. So we can kind of stage heart failure into 4 kind of progressive steps, if you will. A stands for at risk, which is pretty much everybody. I hate to say it, we're all pretty much at risk for heart failure. People who smoke or have high blood pressure or high cholesterol, or have a family history is all at risk. B, we define as beginning. So maybe you've had some testing that suggests that the heart isn't contracting normally, but you don't really have any symptoms. That we call stage B. It may be worth going to see a cardiologist at this point, because there are medicines that we can use to kind of prevent things from going further. C is what we call classic. That is kind of what you may think of when you think of heart failure. The patient can't breathe, maybe they need to go to the hospital to get fluid, to get them to pee off fluid. This is really where we are aggressive about using medicines and devices to improve these patients. And then D, it means, in my mind, stands for deteriorating, which means that despite our best efforts, things are getting worse. And this is when we consider advanced therapies, which I'll talk about in a second. So I mentioned medicines for heart failure. We call this goal-directed medical therapy, or GDMT. Basically, there's a bunch of medicines out there that improve heart function, but they only work at really high doses. But the problem is you can't start the medicines at high doses because it makes the patients feel awful, and it may actually make the heart failure worse. So what we have to do is we have to take these heart medicines and introduce them slowly, gradually, carefully, paying attention to each patient and going up in a sort of an individualized way. If we can get the medicines as high as we can, and the patient tolerates it and feels good, then they live longer. They have less symptoms. They're less likely to go to the hospital. And in fact, sometimes we see that the heart function may recover and come back to normal. This is what I spend a lot of my time doing. This is the bulk of heart failure care in modern medicine. There's many different types of heart failure medicines. I do not want you to remember any of these. It's really just to make the point that there's a lot of them. There's medicines that help block there's medicines that block hormones from the kidneys. The newest one on the block is called Entresto. It's very popular. You might see it advertised on TV. There are these things called beta blockers, which helps relax the heart, blocks hormones from the brain, prevents dangerous heart rhythms. There's these medicines called aldosterone antagonists, which block hormones from the kidneys, which are bad. And then there's these newer medicines called SGLT2 inhibitors, which were designed for diabetes, but we found in patients with diabetes that they didn't die from heart failure. And so we started using them on patients with heart failure, and indeed they started to live longer. And so these medicines help the body excrete sodium and keep the fluid levels in the body good. There's a bunch of other heart failure medications. Please don't worry about it. There's tons of them. Another big part of heart failure care is thinking about devices, things that we actually implant into the patient's body. So there are certain patients with heart failure who may develop life-threatening heart rhythms. And if we've gotten pretty good at predicting who those patients are. And so what we may recommend is that we implant a defibrillator. A defibrillator is basically a device that is surgically implanted under the collarbone here. And it has wires that are inserted into the blood vessel, and it goes down into the heart. And this device has a battery and a computer, and it watches the heart rhythm 24/7, 365. And if one of these dangerous heart rhythms happen, the device will give a shock to the patient to get them out of that heart rhythm. And it can save the patient's life. A newer technology that we're starting to use actually at the University of Maryland, we're starting to roll this out, is this thing called vagal nerve stimulation. In certain patients with heart failure, their symptoms are really bad. We can implant a device, again, with a little electrode that goes up to the nerves here in the neck, and it gives a small, imperceptible little electrical impulse, and that can relax the nervous system, the sympathetic nervous system, and allow patients with heart failure to have less symptoms. This is very new. And then there's this thing called cardiac resynchronization therapy, which for certain patients with heart failure, we can implant pacemakers where instead of the wire only going to one side of the heart, we actually place it on both sides of the heart. And then this device has an even more advanced computer that actually times the impulses of the electricity and helps the heart coordinate. Some patients with heart failure, instead of the heart doing this, they start doing this. As you can imagine, this is not a very efficient way for a pump to work. And so this device basically tells the heart, and then gets the heart to start contracting in a more coordinated way. Patients with these kind of pacemakers live longer, have less symptoms, go to the hospital less often. And then we already talked about mitral cup earlier. Some patients with heart failure may need their mitral valve fixed. So then, if we do all the devices and all the medicines perfectly, some patients may get worse despite our best efforts. This is what we call stage D heart failure. This is when we think about advanced therapies, which may be a heart transplant. As you can imagine, a major surgery where the old heart is removed from the body and a new donor heart is placed. Unfortunately, in the United States, we don't have enough donors as we need. More patients die waiting for heart transplants than we're able to do. But the patients who are able to get it live longer, fuller lives, and it's a really effective treatment for very advanced heart failure. And then a newer technology is this thing called the ventricular assist device. Dick Cheney had one of these, if you're familiar. Basically what it is it's a pump that is surgically implanted at the base of the heart. And it has a little cannula or a little tube here that basically pulls blood out of the heart and then pumps it up this tube and out into the body. So you basically bypass the entire heart. This pump is basically this magnetically levitated space-age device that continuously turns and puts out about 5 to 6 liters of blood flow every minute. And it's truly an amazing piece of technology. This is something that some patients may need either as their final treatment for heart failure. You can live with one of these devices, you can go about your life living with one of these pumps, or sometimes we use it to try and stabilize the patient long enough to get them to the heart transplant. We call that bridging. And something that's very exciting that's happening in the University of Maryland, I'm sure you may have heard about this a couple of years ago, the first time ever in humankind, a xenotransplantation was performed at the University of Maryland, where we took a pig heart and implanted it into 2 patients. The thought process behind ethics aside, and depending on how you feel about that side of things, the reality is we just don't have enough heart transplants in this country, or in the world really, and so the thought is perhaps we can use animal organs to try and help some of these patients. And the first 2 were performed at the University of Maryland. This is by no means ready for prime time, ready for treatment, but I think it's coming at some point. It's just a matter of when.
They survive?
Yes, they did, but not as long as we would have liked. I think that's fair to say. All right, so that's heart failure. What questions do we have about heart failure? No? Good.
Symptoms on that are different for women than they are for men, right? Or am I thinking just stroke?
For heart failure, I think symptoms tend to be pretty similar. Every person is different, but I think between genders, it tends to be pretty similar. Angina definitely tends to be very different. And stroke, yes, different. But heart failure symptoms tend to be heart failure symptoms. Yes?
If someone had an incident 20 years ago and they're on a beta blocker, so it's an arrhythmia,
Mhm.
and nothing's happened since and they're continuing a very low dose of beta blocker, is there any harm being done?
Good question.
Because you had an instance there.
Yeah, we're going to talk about heart rhythms in a second here. My philosophy, depending on the heart rhythm, is if it ain't broke, I'm not trying to fix it. So if a patient had a serious heart rhythm or a very symptomatic heart rhythm and they get placed on a little bit of medicine to help and then they do great, I tend to leave that alone. There's not a lot of harm in being on these beta blockers on the long term. There could be a lot of harm to having a sudden heart rhythm. That's kind of my philosophy. It all kind of depends on the rhythm and the patient, but that's kind of how I think about it, if that's helpful. That's a good question. Any other questions for heart failure before we wrap up with heart electrics? All right, perfect. We're in the home stretch here. All right, so we've got some rhythms of the heart. Rhythms of the heart can either be fast or slow. The most common type of fast rhythm from the top of the heart is called atrial fibrillation. Very common. Lots of people have it. It becomes more common every decade of life. So every decade we get older, it becomes more common. Basically, what atrial fibrillation is instead of that conduction that I said, top, middle, go down through the chambers, there's electrical chaos going on in the top part of the heart. There's lots of signals coming from lots of places. It's swirling around. It's chaotic. And so that pacemaker, that speedometer cell that I mentioned in the middle, gets bombarded with tons of signals at irregular ways. And so then the heart ends up going fast and irregularly.
It's like a seizure in the heart.
That's
What happens to the brain. And the seizure.
that's a very good way of thinking about it. And much like seizures, we don't fully understand what causes atrial fibrillation. We know about some risk factors. That is a good way of thinking about it. I hadn't thought of that. Patients may have shortness of breath. They may have palpitations. They may feel fatigue. We care about atrial fibrillation for kind of three reasons. One is it causes symptoms, right? We don't want patients to have symptoms. Symptoms can be debilitating. Two is it actually predisposes patients to stroke. So if the top chamber of the heart is electrically chaotic, the top chamber of the heart doesn't contract. It's just basically wiggling. And blood can pool in the corners here. And if the blood pools, it can form a clot. And if it forms a clot, that can flick off and go to the brain and cause stroke, which can be devastating. So we're able to kind of predict people's stroke risk, and we'll talk about treatment in a second. And if we leave someone in atrial fibrillation for a long time and their heart rate is super fast all the time, that may cause heart failure over time. So that's why we care about atrial fibrillation. The way we treat atrial fibrillation, big one is stroke prevention. So we can kind of predict who's at risk using this special calculator, which I won't go into, but we can predict risk. We typically prescribe blood thinners to patients to thin the blood to prevent these strokes. And a newer kind of technology that's out there, you may have seen this also on TV, is this thing called a Watchman or left atrial occluder device. This is typically reserved for patients who can't tolerate a blood thinner. Maybe they have bleeding issues, nosebleeds, bleeds from below, whatever the issue is. And again, the catheter goes in the vessels in the groin. It goes across the wall between the atria. And this device, it kind of looks like a jellyfish almost. And the jellyfish device is basically plugged into the area of the heart where most of the blood clots form. And then it stops blood from pooling in there and reduces the risk of stroke. And then in terms of symptomatic treatment for atrial fibrillation, it's kind of rate or rhythm control. We generally try to slow the heart down, or we use medicines or procedures to keep patients in their normal rhythm. There's this thing called the atrial fibrillation ablation that's out there.
A little bit bigger for
Oh, thank you. That's beautiful. Wow. Basically, what we do is we use catheters to, again, vessels in the groin. These catheters have the ability to map out the heart electrics from the inside, and we take these catheters up, map out the electrics, and then we can apply little bits of heat or cold to basically burn, believe it or not, or freeze areas of the heart and prevent atrial fibrillation from forming. It's kind of the same concept as a wildfire. So a wildfire usually starts in one place and takes over the entire forest. We can kind of figure out where it's coming from and kind of burn or freeze near that area and prevent the wildfire from taking over the entire heart.
Do you use a camera? Where it's
That's No. So I don't do this, but the electrophysiologists do this. They basically, I showed you the angiography at the start, the how we use contrast dye they use that technology, plus these catheters themselves know where they are in space, believe it or not. So on a screen, they can see where they are inside the heart. It's advanced, telemetry, and they know exactly where they are using basic computers. There's a heart rhythm that's similar to atrial fibrillation. We call it atrial flutter. It's kind of similar in the sense that patients feel it kind of in the same way, similar symptoms. Stroke risk tends to be less, and it tends to be easier to control. But the difference between flutter and fib is instead of the electrical chaos that I mentioned, there's a circuit basically spinning around inside the top chamber of the heart really fast. And that circuit sends off signals and causes the bottom part of the heart to contract. And it tends to be fast and regular. And then there's a grab bag of other fast heart rhythms that come from the top of the heart called supraventricular tachycardia. This is basically all the fast heart rhythms from the top of the heart that aren't fib, aren't flutter. We tend to lump them all together because they cause similar symptoms, but the way they're different from fib and flutter is they don't cause stroke risk. So patients with supraventricular tachycardia, we don't put on blood thinners, and we tend to treat these to try and help patients feel better. And these are just some different types. Depending on how the electricity is moving around the heart kind of determines the type of supraventricular tachycardia. And then there are two fast rhythms from the bottom part of the heart. Ventricular tachycardia, which is basically a rapid heart rhythm that's coming from the ventricle up. It's usually associated with heart failure or prior scars. And then there's this thing called ventricular fibrillation, which is associated with ischemia. These are both life-threatening emergencies, or they can be, I should say. They could be life-threatening emergencies, and we tend to treat them with medicines, defibrillators, ablations if we need them. And then the last thing I'm going to mention is there are some slow rhythms of the heart. We call these bradycardias. In this realm, things are extraordinarily important. Not everyone who has a slow heart rate, it's not necessarily dangerous. But if patients are having symptoms, then we want to sort of investigate this and perhaps help them with treatment, which I'll mention in a moment. Fatigue, dizziness, passing out may be potential symptoms of this. Your doctor may want to test whether you're what's called chronotropically competent, which is basically putting a patient on a treadmill and seeing how fast the heart rate can go. And then the EKG itself tells us where the issue is. This is really small, and I apologize for that. But basically, the pattern of the EKG tells us what part of the heart is the issue. So if you can imagine here, so this is the signal from the top part of the heart. This is the signal from the bottom part of the heart. Here you can see they kind of match. Here they match, but they're getting further and further and further away, and then eventually the top signal causes nothing. This is called Wanky-Bach. And then there's this type 2, which is basically randomly the heart will not conduct for whatever reason. And then here is basically the top signal from the heart is completely dissociated. It has nothing to do with what's going on in the bottom part of the heart. This one can be potentially life-threatening. And the way we treat this is with a pacemaker. I actually brought one today. Pacemakers are about this size and weight. We can actually pass it around. I get no money from Medtronic, so. The pacemaker, similar to the defibrillator I mentioned, is inserted under the collarbone with wires that go down into the heart. And then basically this device watches that heart rhythm I was just showing you. And if a signal doesn't go through, this device will give an imperceptible pulse of electricity and cause the heart to contract. And it can be very effective for treating symptoms. I think what we were maybe mentioning at the start was that these pacemakers remotely translate these days. So I get signal transmissions from my patients with pacemakers. So if they develop a new abnormal heart rhythm, I know about it. So that's what we were talking about.
What is considered to be a low, slow?
So like what's the number? Like what's normal? So The textbook answer is 60 to 100 beats per minute is considered normal. But as with everything in the textbook, everybody's a little bit different. So, it's weird. I usually don't mention Lance Armstrong twice in a talk, but Lance Armstrong famously had a heart rate of about 20 when he's asleep.
Yeah.
So very elitely conditioned athletes may be very normal for their heart to go very slowly. It may also be normal to develop some of these heart blocks while you're asleep. That could be normal. That's why I say symptoms are so extremely important here. If you're feeling fine and you're good and you have no problems at all and you can exercise and do everything you want to do and your heart rate's a little bit slow, I'd say that's fine, generally speaking. So I can't tell you exactly what the number is, but that's a great question. Yeah.
Is that what they call an athletic heart?
Yeah. So the athletic heart does have to do with the heart rate, but it also has to do with actually how the heart rate models. So I didn't talk about this very much during heart failure, but some hearts can get thick. And the question becomes, why does the heart get thick? Is it because of a problem? Or is it like, I'm not going to use my own bicep, but someone else says, what's a bigger bicep? Is it because of athletics causing the heart to get bigger that in certain contexts may be normal? That's usually what we mean by an athletic heart, is that the actual heart muscle has gotten thicker. But yes, it gets slower as well. Yeah.
If someone dies because of an enlarged heart, what does that mean?
That is usually describing heart failure. So I didn't really get into, these are really good questions. I didn't get into this very much, but basically as the heart gets weaker, it can tend to dilate. So, I was showing you the stages of heart failure. Sometimes people around C or D, the actual heart chamber itself starts to dilate and balloon out as the heart gets very weak. Then that is probably what they mean, the dilated heart. That's usually a sign of more advanced heart failure. Yeah.
Yoga and meditation will slow and that's good.
Yeah.
Is it good, really, in a general sense, to have a slower heartbeat?
I think so, yes. I think one of the things that comes up with heart rates is variability, right? So heart rate variability is important. So you're right, when you're relaxed, meditating, sleep, whatever, it's very normal for the heart rate to become slow. But when you go to exercise, when you go to, say, run on the treadmill or play tennis, we expect the heart rate to go up. That's that kind of chronotropic competence thing I mentioned. So if patients are having symptoms related to a slow heart rate, and then they go to exercise, and they can't get their heart rate up. So let's say it starts at 40 and goes to 50. That could be a sign that the electrics are diseased, and the patient may benefit from a pacemaker. Generally speaking, though, yeah, if you're relaxed and the heart rate's low, that's perfectly normal. It's a good question. Okay.
I can get confused about some of these terms.
Yeah.
So, we are talking about heart rate, heartbeat, and then you got the blood pressure.
Yeah.
And so I tend to have very low blood pressure. And so I'm wondering how does that feed into perhaps a slow rhythm, perhaps? I don't know.
It's a good question.
Okay.
What causes a lot of patients and maybe even some providers consternation is, okay, the number's abnormal, right? So the blood pressure's low, the heart rate's low. If the patient's feeling fine, not having any symptoms, heart function's normal, they're feeling good, they can do everything they want to do, I tend not to worry about it too much. Numbers are one thing, symptoms are the most important thing in the world. Now, that's kind of it's hard for me to make a blanket statement about every human being, but generally speaking, if people have low heart rate, low blood pressure, but feel great, they can do everything they want to do, they're exercising, I tend not to worry as much about those people. Now, of course, if that patient is then having extreme fatigue, they can't exercise, they're dizzy when they stand up, they can't do the things they want to do, that's when I say, okay, this is something we need to go investigate a little bit more.
Thank you.
You're. All right. I think that is excellent. So I want to. So this is Jackie and I's cat. This cat here, his name is. I told you the electrical system. It's called the Hiss per Kinji system. So his name is Hiss per Kinji. That's his name. And that's Wilson in the background snoozing as well.
Unique Wilson.
Yeah, Jackie named Wilson. That's true. It's funny, yeah, they've done studies on this. They've randomized patients after heart attacks to a pet, dog or cat. The patients who get dogs actually tend to do better. Cats, no. Nobody's really sure why, but they think it has to do with lower stress, like you were mentioning, stress, exercise, right? If you've got a dog, you've got to go walk. So there may be something to that.
Did you have some things you wanted to show?
Yeah. Actually, so I brought some toys to play with.
May I ask a question?
Of course.
Could you just speak just a little bit about PVCs and PACs?
Oh, thank you. Yes. Great question. So PVCs and PACs are basically singular events of those heart rhythms I was mentioning. So a PAC is a single beat that's not coming from the conduction system, from the top chamber of the heart, and PVCs are a single electrical impulse that are coming from not the electrical system in the bottom part of the heart. You could think about it as like a momentary ventricular rhythm or a momentary supraventricular. The question's a really good one. Everyone gets these extra heartbeats. So the way, I mentioned the heart has the SA node, the AV node, and the conduction system, but the reality is every single cell in the heart can be a pacemaker cell if it wants to. The thought is that that's kind of built in some redundancy, right? So every cell can kind of kickstart and create an electrical signal if you need to. But the problem is it can also cause symptoms. Some people can be very symptomatic from these extra heartbeats. So if you imagine your heart has a rhythm that's going down through that conduction system that I keep talking about, but then all of a sudden a cell over here sends off a signal and it interrupts that rhythm. The heart will usually pause for a moment after that extra heartbeat, and people can feel that. People may feel a sudden, can't catch my breath, they might have a moment of chest pain, they may just not feel right, a flip-flopping kind of sensation in their chest. So lots of people have PVCs, but not everybody feels them. And so patients who are symptomatic from their PVCs or PACs, sometimes we like to give medicine for that to make patients feel better. Does that sort of answer your question?
Yes, it does. I didn't mean to interrupt your things there. Go. But thank you.
All right. So what I brought, I actually brought what I actually brought the catheter and the balloon that we use to inflate a stent.
Gonna show up on the screen.
It'll be appear on the screen.
So put your finger here. Yep, I promise that hasn't been inside anybody. And so basically what we do here is, during the intervention, this little balloon here is advanced. It has a stent loaded on top. It's advanced to where the blockage is. And then the interventionalist will, I'm not sure if you're able to see it, but that little
See if
balloon.
I can get it. Sorry, I need to move that.
We can also sort of pass these around. These balloons are then inflated and then deflated, and what's left behind is the stent. And so people can come check this out if they're interested. What I also brought was this thing. We didn't really talk about this as much during the talk, but in very bad heart failure, we may place catheters inside the heart to measure those pressures that I mentioned. We introduce these through the veins in the neck. It's guided up into the chambers of the heart. And this can either be temporarily used to measure the pressures inside the patient's heart or left in, actually, if they're awaiting transplant. And then I think the last kind of fun gizmo, I actually brought a temporary pacemaker as well. Sometimes in emergency situations, like with that third-degree heart block that I mentioned, sometimes we use these catheters to introduce a pacemaker into the patient's heart before they're ready for the permanent pacemaker. This is usually kind of an emergency kind of thing, and this is just kind of what it looks like. We can feel free to come take a look at these if you're interested. That's pretty much it. That's all I got.
So, a regular cardiologist, would he use these or would it be an electrophysiologist?
Yeah, good question. It kind of depends where you are. So, at a large academic hospital like the University of Maryland Medical Center in Baltimore, they have every flavor of cardiologist you can imagine, right? If you go to a more, rural area, some of the general cardiologists may do some of these things. Some of the general cardiologists may place pacemakers, may place stents. We're kind of trained to do all of these things. I don't. You don't want me doing stents and you don't want me placing your pacemaker. I let Dr. Etherton and Dr. Sardi do that. But in some places they do, to answer your question. It all just kind of depends. Yeah.
So my mother had a pacemaker, and everybody in the family would call her the Energizer Bunny.
Yeah.
And I think she was an Energizer Bunny before the pacemaker, just the way she just kept on doing things.
Yeah.
And she just wore herself out. But then the pacemaker really did extend her life, decades. Yeah.
I thank you for pointing that out. Every time I send a patient for any procedure, I hope they get the most possible benefit out of it. That's always the hope. Some of the symptoms like shortness of breath and fatigue, it can be tricky to say that it's the low heart rate definitely causing this. Sometimes we've got to do testing and try and be as sure as we can before we send the patient for the pacemaker. So if she got that outcome, was the Energizer Bunny afterwards, live longer, I think that's fabulous. I think that's great. I hope everyone has good outcomes when they get these kind of procedures. Yeah.
Do you believe that instead of taking, lipids, that people can reduce their LDL and increase their HDL and decrease triglycerides, with over 6 months or a year, they can do that, maybe get it down? And then what happens to the LDL? You were showing how it thickens in the artery. Does it just dissipate and kind of get smaller and go away? What?
Good, very good questions. So, yes, diet and lifestyle has a role to play in cholesterol. What we eat, how much we exercise, does play a role. However, there are genes that are associated with cholesterol. So you may be eating nothing but rabbit food, running marathons like my brother, and your LDL may still be very, very high. So yes, it definitely plays a role. There's just no doubt about it. Eating right and exercising is important. But you could be doing everything right and still have very high cholesterol. What's interesting about the cholesterol story, in my opinion, is that cholesterol works at a population level, right? So if we take 300 million Americans and we look at the people with the most cholesterol, they're going to have the most heart disease. But if you zoom in on the individual, that may not always be the case. I think any cardiologist will tell you, I have patients with low cholesterol who get heart disease. I have patients with high cholesterol who don't get heart disease. That's why we start to do some of these other testing that I mentioned. That coronary calcium scoring can be very, very useful. So if your cholesterol is off the walls high, and we do a coronary calcium score, and your coronary calcium score is 0, you don't really care what the cholesterol is, to be honest with you, because there's no hardening in the blood vessels. And there's an argument to be made. The current literature is that if you have a coronary calcium score of 0, you don't need to be on a statin no matter what the number is. So I think cholesterol treatment needs to be kind of personalized to the person. That's for prevention. If you've had a heart attack before, you've had a stent, or you've had your bypass, then we tend to be really aggressive with those people no matter what, because of some of the other effects of statins, the anti-inflammatory effects, the plaque stabilizing effects. And so for people, we call it primary versus secondary prevention. Primary is you haven't had a heart attack yet. Secondary is you've had a heart attack. People with heart attack should be on a statin. For the primary prevention, I think we need to be a little more personalized than saying just everyone should be on a statin. That said, I'm on a statin, if I'm telling you the truth. I had my doctor put me on one because my cholesterol's really, really, really high, in all truth.
Are there variations in the pacemakers that you put in? As an example, my mother, part of her heart was beating, but not the other part. They put in a pacemaker, and she lived to 101 and no problem.
Fabulous. Yeah, there are lots of types of pacemakers. They all kind of have to do with what the electrical problem is. A lot of the ways we describe the pacemakers has to do with how many leads it has or how many chambers it has. Okay. So if it's kind of a simple issue, sometimes we just do a single chamber, single lead pacemaker. If it's a more complex electrical issue, they may have 2 chambers and 2 leads. And then, I mentioned in heart failure that cardiac resynchronization thing, those patients may have 3 leads, 3 chambers. So there's many different types. One of the things I didn't mention is a newer thing is called the micro, which is actually a pacemaker that is loaded on a grappling hook, and it has no leads. We call it a leadless pacemaker. And that grappling hook device is planted on one of these catheters, and we basically embed it into the heart muscle, and then the whole thing comes out. So there's no leads for the patient. The pacemaker itself lives inside the heart and paces the heart from the inside.
Does that
How
last
does it
longer?
get power?
It has its own battery. It has its own battery, it has its own computer, doesn't last as long. So we typically reserve it for older patients, because you're right, we can't retrieve it, we can't change the battery, it's kind of a one and done kind of thing.
But you don't have to do open heart surgery.
But you don't have to have the small pacemaker placed. There's no weight restriction. It's kind of a one and done, and that takes care of it. Not everyone's a good candidate for this. That's why I didn't really point it out. But there's lots of types of pacemakers. To answer your question, it's a good question. Yes.
When you say older patients, you just define more what.
I was hoping someone would challenge me on that. It depends. I don't like to use the O or the A word in the clinic because everyone's so different. I think in the scientific data in cardiology tends to be around 75. But like I said, everybody's very different. Everybody ages very, very differently. But when I say older patients, I'm usually thinking older than 75, probably into 80s in my world. You're welcome. To make you feel better, before 65, we consider premature. So if you get heart disease at 64, that's premature. Yeah.
What are some of the procedures you can do here versus having to send them the vault?
Yeah, good question. So here in Easton, our interventionalist, Dr. Etherton, Dr. Sardi, do a wide array of stenting and diagnostic coronary angiography. Dr. Etherton places pacemakers. The micro kind, the other kinds that I showed you. We do all kinds of echocardiograms, we do TEEs, we do all the nuclear stress testing. That's sort of the menu of stuff that we do here in Easton. The nice thing is because we're all one kind of system, we're very close with the cardiologists in Baltimore. So if we need to send someone for a TAVR or a defibrillator, speed dial kind of thing, you can pick up the phone and call. But to answer your question, the specific stuff we do here in Easton, stents, a lot of diagnostic things, pacemakers are the really big ones. Yeah, you're welcome. Yes.
Can you explain a heart murmur?
Yeah. So a heart murmur is just basically the blood going fast. So a murmur is we hear the blood's going fast. That may be a sign of a valve issue, but it can also be perfectly normal. So I kind of mentioned earlier that EKGs are sensitive but not specific. If you hear a murmur, that could be perfectly normal. Some people just get murmurs, but it can also be a sign that there's an issue. So a lot of times, if a doctor hears a new murmur, they'll send the patient for the echocardiogram to make sure there's not a valve problem.
Kind of common in kids too, as they're growing. I mean,
Extremely
Yeah.
common.
and they grow out of them.
Extremely common. They can come and go. They can be dynamic. They can be here one day, not the next. One doctor hears it, another one doesn't. Murmurs, murmurs are tricky business. But typically, people with a real, I shouldn't say real, but an advanced valve disease, they'll have a murmur that's there all the time. And it has a signature sound, so a lot of the boards that I have to take is like figuring out what murmurs what. But what I would say as a general statement, if a doctor hears a new murmur, they'll typically send you for an echocardiogram to make sure it's benign. It's kind of the way I think about it. Yeah.
So when I was growing up, yes, I did have a heart murmur that was monitored.
Yeah.
And when I was young, I had an older brother. He ended up having heart surgery. This was back in the 60s when they were first being done.
Mm-hmm.
And he had, it was in DC.
Mm-hmm.
So he went in, it was supposedly a hole in his heart.
Mm-hmm.
What does that term mean to you?
So there's a whole, I kind of talked about the four sort of most common sort of buckets of cardiology. The fifth, which I didn't really talk about in the interest of time, is called congenital cardiology.
Okay.
So heart issues that we're born with. That is a whole lecture in and of itself. Basically, all the things we talked about today, you could be born with a problem with it. So, there's tons of things here. Frequently, depending on how bad or how problematic the defect is, then a lot of patients may need surgery for it, like you're saying. When we say a hole in the heart, what that means to me is basically an abnormal connection between one of those four chambers that we talked about. It could either be at the top, it could be at the bottom, side. There's lots of different kinds. But that's what that means.
Thank you.
You're welcome.
Okay, great.
Huh. That has a lot of information.
Yeah.